Hello, am I audible?
Yeah.
Yeah. So good evening, everybody. So today we have a very young and dynamic faculty, the Dr. Shamnath from Kozhikode. He's consultant neonatologist in Baby Memorial Hospital, and he has got excellent academic credentials. And he will be talking about the neonatal X-rays, which is a very important part not only for the exam point of view but also throughout your neonatology career, because the X-rays are something still, although there is ultrasounds are freely available, but still X-rays has got its own merit and its own go-to investigation in many of situations, and in many of the emergencies it does help us to manage. So it's very important that we all should be thorough regarding the neonatal X-rays, and I guess I am sure Shamnath will take us through in a very simple and systematic approach. Over to you, Shamnath.
Thank you, dear Dr. Binish, and sorry for the participants for the technical glitches for the delay. And first of all, I would like to thank the NOEL team for giving me this opportunity to be a faculty in this excellent session. Without much delay, I would like to proceed to our session. So,
Shubhna, we can't see your slides actually.
no, I am just sharing only. Yeah,
Okay. Yeah. Now it's visible.
yeah. So, okay. We'll be dealing with the X-rays in a brief. The learning objectives of today's presentation would be how to schematically read and describe a neonatal X-ray, chest X-ray. And it is in no way to replace a radiologist's opinion, and identify the typical features of our common neonatal conditions and understand the nuances, variations, and overlaps in the radiological picture, as well as identify the complications of the disease. First, I would like to see whether, in these scenarios, do we need to do an X-ray or not? That is routine pre and post extubation. That is after re-intubation to confirm the tube position, as well as desaturation or increased FiO2 requirement, or to document lung clearance. In all these scenarios, do we need to do a X-ray or not? That is the first question we need to answer. Is it a rule that we need to do X-rays in all cases of routine pre or post extubation or after re-intubation? I think you people can post your answers in the chat box. I'll be seeing. Hello, you can post the answers in the chat box.
They can post the questions in the Q&A also. I think that can be also answered in the end, Shamnath.
Oh, yeah, sure. Okay.
Yeah, you can take it up in the end actually. Okay.
Yeah, sure. Okay. In all these scenarios, it is not a routine that we do. In all these scenarios, we do not do a chest X-ray. So the answer would be no. Now, what about these scenarios? That is for diagnosis and planning treatment of conditions such as respiratory, GI, cardiac conditions, to check the position of endotracheal tube, umbilical, arterial, and venous lines, as well as chest tube, as well as in case of acute respiratory deterioration. In all these cases, do we need to do an X-ray or not? And in this case, the answer would definitely be a yes. Now, before proceeding to the topic per se, in whatever unit you are working, first, there are certain basics that we all need to follow before we do a neonatal X-ray. So first and foremost thing is adequate protection for the person who is doing the X-ray, as well as the staff nurse or resident who is positioning the baby. Ensure that till the moment the X-ray technician keeps the machine, try not to shift the top end of the warmer. Ensure that the baby is in correct position. Ensure the comfort of the baby. And now, particularly now, all of the newer warmers, They come with sliding port for the radiologist to keep the X-ray panel. So you needn't disturb the baby. This will be particularly important when you are doing X-rays for maybe intubated babies, babies with PPH and all, where we try to keep it as less handling as possible. So always ensure that you provide the baby adequate comfort. Also check the field of view, cover the cassette. Don't, as far as possible, no, don't keep the baby directly on the cassette, because try to cover it with a sterile sheet so that asepsis is also taken care of. And many of your sick babies for whom you order the X-ray, they'll be having ET tubes in situ, USC, UVCs in situ. So ensure that once the X-ray is done, these lines or tubes are not disturbed. And also, like many a times, you speak with the radiologist and try to arrive at an adequate exposure of your films, because many a times it will be overexposed or underexposed. That will be coming in the subsequent slides. But at least have a chat with your radiologist of your unit and ensure that you get a adequately exposed film. These are a suggested exposure ranges. Now, whenever you see an X-ray, there are like these are like a 5 radiographic densities in order of increasing brightness. So you can see that the air is the least bright. It usually appears as dark, and as you move towards like other structures, they are like more brighter. Fat, then fluid is more brighter than the fat. Bone is more brighter, and the most bright is metal, which you don't encounter routinely. So the heart is usually the one which you see as the bright one, and on either side you get the black, which is your air. So whenever you proceed to an X-ray, so I would like to see, like on the left image, you see an X-ray film where, in addition to the neonates limbs, you are also seeing the limbs of the person who are doing the X-ray. So never in your unit you should be tolerant to these type of X-rays. Train your staff well in advance itself, or also the technician, that you don't need the whole film with the limbs of the person who is holding the baby also. So this is a wrong X-ray. The second, you can see this is the correct X-ray. And as far as possible, like in many units, what we see, or what we come across the many neonatal X-rays, if you order a X-ray for a chest condition, this is the image usually the X-ray technician will bring. The X-ray of the chest, abdomen, and it's more like an infantogram, because for neonates, it is very easier for them to take an infantogram. So whenever possible, try to keep your focus to the minimum. If you are concerned with the pathology of the chest, also only ask the technician for the chest film only. And if you need to have a look at the lines and all, then there is the scenario where we'll have to need the X-ray of both the chest as well as abdomen. Now, by convention, all neonatal X-rays are antero-posterior. We don't take a postero-anterior view in neonates. So neonatal X-rays are always antero-posterior. Okay. Now, second thing is, why do we need the film image you are seeing on the right is a lateral X-ray. So when do you need to see need to take a lateral X-ray? So the lateral X-rays are particularly important when you need to assess small air leaks, assess fluids, as well as any space occupying lesions. Okay. Also, some pneumothoraxes like anterior pneumothorax, which are more visible on a lateral X-ray. So it is not that we need not take a lateral X-ray. It again depends on the scenario. There are certain clinical conditions where you will need to order a lateral X-ray also. Okay. Now, the first, before reading any X-ray, you should ensure that it is the correct patient, because there will be so many neonates with the same mother's name. So everyone will be baby of so and so. So ensure that you are taking the correct patient. Identification, check the ID, hospital number, and the last one also date, because particularly in preterm neonates, over the course of neonatal stay in the ICU, they'll be having a bundle of X-rays. And many a time in your rounds, you might even mistakenly, the staff might give you an earlier X-ray with perfectly findings, the findings which you are not anticipating in the baby in the front of you. So always ensure that it is the correct date of also is correct, and you are dealing with the recent X-ray. And or the technical details like side marker against features such as apex of the heart and air bubble in the stomach. Okay. Now, after checking the correct patient ID, the anteroposterior view, then you can comment on the rotation. So this is again just revision of UG. You should ensure that the X-ray is well centered and not rotated to either left or a right. So in this image, the one in the center is the correct one. And how do you decide that? Because both the clavicle should be equidistant from the center. And if it on any side, if you feel that the clavicle is not equidistant, you feel that it is rotated. And the side to which the clavicle distance is more, that is the side to which it is more rotated. Okay. And rotation will lead to prominence of your ribs, prominence of your hilum, prominence of your cardiac shadow, as well as vascular markings. Now, after rotation, next comes exposure. So the first image, you people are not even able to make out the X-ray because it is entirely white. Second, it's okay. You see a black lung and a white heart. Third, it is entirely dark. So the first film is an underexposed film or a soft film. Then this is the center one is the normal exposure, and the one on the right, it is an overexposed film. So after rotation, you should ensure that your X-ray film is correctly having correct exposure also, not underexposed or not overexposed, because you will be missing many of the findings if the exposure is not adequate. Okay. Now, after the basics, that is the prerequisites of doing the X-ray, correct patient, correct site, correct ID, exposure, rotation, your markings and all. Now, how to do or go about reading an X-ray? So in your exam also, like how do you approach to read an X-ray? And many a time, yeah, because the time limit will be very minimal in your OSCE session for an X-ray. But whenever someone asks you to read an X-ray, always go but in a systematic way. Even if you are seeing a striking pneumothorax, first comment on the basics, that this is a chest X-ray, anteroposterior view of the neonate, and some people go from airway down, or some people go from the finding and up. So the order typically a simpler approach would be to go by the A, B, C, D, E, F approach. We'll go with the individual letters. First one is A. Now A stands for airway, hilum, and mediastinum. So first comment on the airway, hilum, as well as the mediastinum. And always whenever you comment on anything in your X-ray, comment whether it is unilateral or bilateral. How is the symmetry? Is it symmetrically present on both sides, or is it asymmetrical? Third, whether the shadow which you are seeing, it is a radiolucent or radio opaque. And whether it is a diffuse radiolucent or radio opaque opacity, or is it a focal opacity. So this is the first comment you should give. And we'll just have a look at some shadows which we usually see. So this is an X-ray where you can see an entirely white thing on the one side. This could. What all would be your possibilities? I think the participants can put it in the chat box. So what are the possibilities which you can have? Okay. So the white lung shadows, which we normally encounter in an X-ray, they are either a collapse or an effusion or a consolidation. Now, consolidation we usually only rarely encounter in neonates. Effusion and collapse both can say, now both are like white opacities. How will we differentiate between both? So here in collapse, you can see the trachea is deviated to the side of your homogeneous opacity, whereas here you can see the trachea is deviated to the left. So in effusion, typically it will cause the mediastinal shift to the opposite side, whereas your collapse will cause your shift to the same side. Now, same coming back to some black opacity. So this is very clearly evident. So for the one on left is a pneumothorax with an ICD in situ. You can see the big pneumothorax and the collapsed lung margin. And this is a space occupying lesion, which is seen as a black opacity. So these are some examples in airway where you can see white or black opacities. Next, the what which you comment is on the bones. Now, this again, many a times, the one on the right is easily identified where you have a congenital absence of the ribs. But the one on the left, where even only if you know the history or if you are looking, sometimes you may miss this. The fracture of the clavicle, particularly in big babies, instrumental deliveries, large 4-8 babies born by vaginal route, it's very common, and usually it heals conservatively without causing much trouble to the neuromite. Only you need analgesics. So after airway, look at the bones. How are they? Next, look at the cardiac. Comment on the cardiac shadow. And this is the way how you calculate your CT ratio. The maximum diameter on the right plus the maximum diameter on the left divided by the total transthoracic diameter, and the cardiac CT ratio of up to 0.6 is normal in your neonate. And when you're suspecting a congenital heart disease, again, you can look at the X-ray. If it is a congenital heart disease with a decreased pulmonary blood flow, it will be more like black opacities, blackish lungs on either side, and depending on the condition, whether it is TOF, tricuspid atresia, you will get the finding. And if it is a heart disease, CCHDs with increased pulmonary blood flow, maybe like a case like here, you get an egg on side appearance with increased pulmonary markings like a TGA. So always look at the comment on the cardiac part also. So after airway, bones, cardiac, then look at the diaphragm. Here you can see both the diaphragm margins are intact, and normally the right hemi-diaphragm is slightly upper than the left. And this is again a clear-cut case of a right-sided diaphragmatic hernia. Here you can see the breakage of the normal continuity of the diaphragm with herniation of the loops of bowel into the right hemithorax. And here again you can see a free air under the diaphragm. So this again, it is a case of perforation. This again, diaphragm, you look for the free air under diaphragm. Now, particularly when you are suspecting cases of NEC with perforation, be very watchful to look for this air under the diaphragm, because sometimes very thin rim of air you may miss. CDH, there will not be any problem, even if in your exams you will readily identify. Perforation ones, always have a look, like look at the airway, look at the bones, see any major issues, cardiac part, no issues, then look at the diaphragm. Am I missing something or not? Okay. Now, after diaphragm, in neonates, particularly sick babies, they will be having your ET tubes, the UACs, the UVCs, and the PICC lines. So you should know how to identify the position, which we'll be discussing in the subsequent slides. So the extras basically look whether the ET tube is in correct position or not, UAC is in correct position or not, UVC, and peripherally inserted central catheters. Okay, and the F stands for your fundic bubble, particularly helpful in cases of your TEF and all. Okay, so in summarizing, neonatal X-ray, it is almost always anteroposterior view in neonates, and diaphragm is up to 6 ribs anteriorly and 8 ribs posteriorly, and you have ribs are more like horizontal compared to older children, and a normal CT ratio of up to 0.6 is normal, and an air bronchogram until 1/3 from the midline, which can be normal in the retrocardiac area, because when we go to the findings of RDS, we'll be seeing air bronchograms. So a little bit of air bronchogram from the midline till 1/3 is normal. Okay. And another important finding is the thymus might be very prominent. We'll be discussing the X-rays of different presentations of thymus. So just remember in your mind, neonatal X-rays almost always AP. And this number of position of the ribs is also very important, because in your routinely, people ask you like, what is overexpansion, what is underexpansion and all. So anything which is less than 7 spaces, you call it an underexpanded, and more than 8, you call it an overexpanded. 7 to 8 is an adequate expansion. Okay. And the rib position also will be more horizontal. And here again, sometimes if your X-ray tube is angled upward, you might see a fan-like configuration of the ribs, which many of people might have seen. So ribs, otherwise also it is more horizontal in children compared to children. In neonates, it's more horizontal. CT ratio of 0.6 is normal, and air bronchogram a little bit in the retrocardiac area it can be present, and thymus is prominent. So we come into thymus. So these are some of the X-rays. So can anyone name the signs which are being seen? I think participant can unmute and also say. Which is the sign which of the thymus which is being seen here?
They are answering in the Q&A box.
I am not able to see the Q&A, sir.
Yeah, there's a
Um,
just after the share button.
Okay, got it, sir. Got it, sir. Yeah. Okay, so everyone has told sale sign. So I want to the one. What is A and what is B? B is sale sign. I agreed. What about A? What is A? So it's only sale sign. So I can see a wave sign somewhere by Dr. Jatin. Okay. So we'll come back to the individual signs. What about these two? The one on the C, what is D? So this you feel like a right-sided consolidation patch or something, like a cricket ball sitting in the middle of the right hemithorax. Here you can see thymus looking like a figure of 8 and all. Okay. So with regard to thymus, the most important thing which I would like to for you people to remember would be, in case of thymus, always the thymus usually presents as a bilateral, smoothly outlined superior mediastinal fullness. And this smoothly outlined superior mediastinal fullness, it blends imperceptibly with your cardiac silhouette. And so it is just like with a smooth blending, you see a superior mediastinal fullness. And the sail sign results from a peculiar shape of the thymus appearing triangular with due to a slightly convex right lobe with a sharply demarcated base. Now, this sharp demarcation is very important, and it is one of the differentiation from other mediastinal masses like mediastinal tumors and all, because they will never cause your this sharp inferior margin. It is usually seen on the right, but again, it can be seen bilaterally also. So this is called your sail sign. The next is your notch sign. So there is a prominent notch on the inferior border that is corresponding to the junction of inferior aspect of the normal thymus gland and cardiac silhouette. So this is called your notch sign. Then you have what is called your wavy thymus sign. So it is corresponding to a soft undulation on the thymus, and it is produced by the impression of the rib. So you can see a wavy margin of on the either sides. So this is called wavy thymus sign. Okay. So my the take home is like always we'll be discussing in the subsequent slides also. In any case of neonatal X-ray, before you comment on the finding, always have a look at what is the clinical scenario of the baby. So I see so many boxes of figure of 8, figure of 8, figure of 8. So you don't appreciate a figure of 8 configuration of a TOPVC. You will not get in a neonatal X-ray. The neonatal X-ray, TOPVC mostly mimics what cardiac condition? You people can put in the chat box. So the neonatal TOPVC, the figure of 8 configuration, you don't get it in the neonatal period. And again, the previous image, it was looking like a consolidation type of lesion. It can present like a mediastinal mass. So thymus is something which you people should keep in the back of the mind whenever you see something which is above the heart, that is a superior mediastinal, a white shadow, because it can present in a very varied presentation, like this sail sign, notch sign, wavy thymus sign, like an ectopic mass, or like a consolidation mass, or like a figure of eight, based on the rotation of the lungs, whether there is any associated pneumothoraxes and all. So thymus can present in a very varied presentation in case of neonates. Okay. So I see everyone answered RDS. That's very good. Correct. Now we'll move to the first scenario. So we have a baby of S, born at 30 weeks by emergency LSES due to symptomatic placenta previa, requiring PPV at birth. Birth weight is 1.1 kg. The baby developed respiratory distress soon after birth. We shifted to ICU. Baby required CPAP of 550. We could not give the surfactant because the surfactant stock was not there. I think many the hospitals in the government sector still face this issue. And respiratory distress worsened. We needed to hike up the CPAP to 6 and FiO2 to 70%. And we did a chest X-ray at 2 hours. Okay, so can you people put on the chat box what are the findings you are seeing? What are the arrows showing? The arrows on the left. What are these? What are the findings which you see in your X-ray? You can comment. Okay, so air bronchogram, correct? So air bronchogram. Any other comments, like apart from air bronchogram, what are you seeing? So you are seeing diffusely white images on both either sides. So this again, you don't see this much. Here image you can see like diffuse white with air bronchogram. Here it is not that much weight. You feel like something sprinkled, sand particles being sprinkled on your paper-like feeling. That is a fine granular appearance. Okay. So, and what is the one which is being showed on the right? The images A and B, what are they? So I get air bronchogram, ground glass opacity, reticular granularity. Now, what about this, the black things which I have shown here? Image B. Anyone? What are these black small things which are being shown? Okay. So, yeah, air leak, cyst. Okay, so to say an air leak, we'll come to that. Okay, cyst. We are not seeing any cyst here, right? A small cyst. Okay, agree. So, all these images which I have shown, these both and these both, they are all images of your respiratory distress syndrome. We'll come to the findings of the respiratory distress syndrome. So the classical hormone hallmark, like if someone asks you what are the features of an RDS, first your point should be it will be an underinflated lung. Okay, so pronounced pulmonary under aeration, that would be your first point. So any RDS X-ray, underinflation. Now, you may say that once you put on CPAP, the finding may vary. Any baby who is on CPAP, you will get 7 to 8 spaces. But RDS per se, because of the alveolar collapse, they are under inflated lungs. So, pronounced pulmonary under aeration is your first point. Second point, you see air bronchogram. Now, how does this air bronchogram appear? Now, why this air bronchogram appear? Because these air bronchograms are the air in the tracheobronchial tree against the background of this collapsed alveoli. So you see the air in the tracheobronchial tree up to 1/3. I told it is normal. Beyond also you are seeing air bronchogram against the background of your collapsed alveoli. So second finding is your air bronchogram. Now here if you look, you see fine granularity. What is this reticulogranularity? You might be hearing it from many a times. Okay, it looks like reticulogranular opacities. Reticulogranular opacities. Now, what exactly is this reticulogranular opacity? Now, by reticulogranularity, what we mean is air in the terminal bronchioles and the alveolar duct, which are distended. So, the air which is present in the terminal bronchioles and the alveolar duct against the background of your collapsed alveoli. Now, to get again your treatment, the inspiration or your expiratory film might affect your finding. So, suppose in expiration that airway caliber decreases, so you will not get much of a reticular granularity. And in other ways, if you see a baby on CPAP, the terminal bronchioles and alveolar duct will be little more dilated. So these dilated terminal bronchioles and alveolar duct, they are called your causing your reticular granularity, and your treatment, your positive pressure may cause further distension of this dilatation of this terminal bronchiole and alveolar duct, and then they form what is called this type 1 bubble. So in neonates in X-ray, you need to remember only two bubbles, type 1 bubbles and type 2 bubbles. Type 2 will come later. So in type 1, there are 1 to 2 bubbles, mostly seen at the lung bases. And in where they are seen usually in associated with RDS babies. Okay. And so this, again, an RDS X-ray, pre-surfactant and a post-surfactant. So post-surfactant, you can see the white homogeneous opacity has cleared instantly. So these are the stages of your findings in your RDS, where you see reticulogranular pattern, your soft decrease in transparency plus air bronchogram, decreased transparency plus blurry diaphragm and heart, and whiteout lung. That usually with current era of antenatal steroid coverage, you don't see much of whiteout lung. Many a times what you see is your reticulogranularity pattern and your air bronchogram. So if someone asks you four findings, underinflated lung, reticulogranularity, air bronchogram, and whiteout. So that's constitute your RDS. And again, note that CPAP and your treatment may alter your picture. And I see some answers of PIE also. Will come to that. Okay. So the same baby, we did a surfactant, we gave surfactant, the baby was continued on CPAP. The baby had sudden worsening with increased FiO2 and shock. And on intubation, you were seeing bloody secretions were seen coming from the endotracheal tube. So you started on the baby on SIMV mode and other supportive measures. So a baby of surfactant, a baby RDS baby on CPAP, you gave surfactant. Post surfactant, you see a worsening. And while you try to intubate the baby for this worsening, you see that bloody secretions are seen coming from the nose and all. You ordered an immediate X-ray, and I'll show you the X-ray. Now, what will be your finding in this case? So an RDS baby had a worsening post X-ray. What is your finding? Yeah, pulmonary. Dr. Ishma has told pulmonary hemorrhage. Any other answers? Okay. So you can see the two images. The one on the right is the textbook image, and the one on the left is a real life image. So if someone asks you what is the X-ray finding of pulmonary hemorrhage, it is the hemithorax appears uniformly opaque and airless because of the hemorrhage. Now, the main clue, rather than X-ray, it is the clinical condition which is your clue to the diagnosis. And many a times, cases of pulmonary hemorrhage, you will see during suctioning bloody secretions coming from the ET tube, as well as while intubation also, sometimes you can see. And typical scenario is when you give surfactant, the pulmonary pressures go down and the left-right shunt happens and it causes your pulmonary hemorrhage. Okay. So we'll discuss two findings till now, RDS and pulmonary hemorrhage. RDS, we discussed the four findings. And in pulmonary hemorrhage, what you see is uniformly opaque and airless lungs. Now, we'll look at just briefly, since we have intubated, this is the X-ray post-intubation. So I want to know these four things quickly in the chat box. What is the correct position of the ET, USC, UVC, and PIC? Fast. We'll go a little fast because I think we'll be a little short of time. So ET tube, USC, UVC, PIC. Which is the correct positions of these four? I don't see any answers coming. UGG. Dr. Vijay Kumar, what is UGG? Okay, so what is correct position of ET tube? What is correct position of UAC, UVC, and PIC line? UVC. So I think I want to know what is the correct position. Okay. So I think we'll proceed. So the with ET tube, the correct position in neonatal X-ray is between T1 and T2. That is between your lower margin of your T1 and upper margin of T2. So anything which is above T1, it will be higher up. Sorry, and anything which is below T2, it will be a below deeply inserted ET where you'll need to pull out. So whenever in X-ray, if you find ET which is down, you can pull out. But if it is slightly up, if the baby is maintaining well, no need to don't never push in the tube or never re-intubate just for saking of keeping it between T1 and T2. But the ideal position of ET tube is T1 to T2. And the next is regarding the UAC UVC. So UAC and UVC T6 to T8, T2 to T3. So T1 to T2 is the correct answer. And UVC, UAC. Okay. And with regard to UAC and UVC, this again, three radiological hallmarks of how to differentiate between these three lines. Okay. Normally, what we do, we put in, since the venous diameter is bigger, we put in the bigger tube for UVC catheter size. Maybe if you are putting 4 for UVC, you'll be putting a 3.5 for the UAC. So sometimes people will be putting the same also, but again, this is a slight clue. Like if you see a bigger diameter one, it is mostly likely to be the artery. Smaller one will be the vein. Now, the next is, next clue or the most important clue is the line which is looping inside the abdomen is your UAC because of the course of your internal iliac artery. The one which is looping inside the abdomen, that is your UAC. And third point is UAC typically goes along the left side of the vertebra. UAC usually goes along the right side and UVC usually courses along the left side. Now, what is the final desirable position? UAC, high UAC is preferred. That is between T6 to T9. And with regard to UVC, it is 0.5 to 1 centimeter above diaphragm. There again, with regard to UAC, you will have different textbooks telling different vertebrae also. Some people telling just at the diaphragm, below diaphragm. But I think majority of the conventional textbooks say it is 0.5 to 1 centimeter above diaphragm. Okay. And finally, what is the ideal position of the peak? If it is an upper limb peak, you should measure till the sternoclavicular, your acromion process, and then till the right second intercostal space. So if the peak for your peak to be in the central position, it should have traversed medially. You can follow the red arrows, and then it should curve, and it should finish just outside your cardiac border. That is 1 to 2 centimeter outside your cardiac border. If it is going inside, you should pull out. And it should cross medially, then only you can reasonably be sure that it is in the IVC or whatever, your central vein. Now, for ET tube and PIC lines and UVCs, nowadays, POCUS has come up in a big way. But still, in our settings, we still rely many a times on the X-ray to identify these lines. So again, I am revising ET tube between T1 to T2, UAC between T6 to T9, that is high UAC, which is preferred because the complications are less compared to a low UAC. UVC, which is 0.5 to 1 centimeter above the diaphragm, and the PIC line, which has any line which has traversed medially and which has gone in ending just outside the cardiac seal hood. Okay, now you intubated the baby, and I think that scenario is done. We'll go on to the next one. So term neonate at 40 weeks, born out of normal vaginal delivery with meconium stain like cried immediately. The baby developed respiratory distress. You have a term baby with tachypnea with a history of MSL. It's a vigorous MSL baby. And you feel the distress has slightly worsened later, like maybe at 4 to 6 hours. You did a chest X-ray. This is the X-ray you are getting. So what are the findings of this X-ray? Okay, meantime, I'll just, Dr. Ashwini has asked, please repeat UAC, UVC difference. So basically, the one which is looping inside the abdomen, that is your UAC. The bigger size one, if you are finding a smaller size and a bigger size line, the bigger one would be conventionally UVC and the smaller one would be UAC. And the one which is coursing along the left side of the vertebra would be your UVC. And the one slightly coursing on the right side will be your UAC. Okay. And so what is the findings of this one, this X-ray? Pneumo. Okay, good. So that's an interesting comment. Pneumo. Okay. Mixed atelectasis and hyperinflation, Dr. Junaid. So that's an excellent answer. Patchy asymmetrical opacities. Okay. Now, with regard to pneumo, we'll come back to the pneumo. When we discuss the pneumo, we'll come back again in this case scenario. So here, what is your scenario? You have a term baby with an MSL and that baby has a distress. And this distress, usually MSL babies, in RDS, we usually say the distress is maximum at birth. Whereas in MAS, conventionally, the distress usually begins at somewhat like 4 to 6 hours. Okay. So here, compared to an RDS, what is the first striking thing in your X-ray? So someone told pneumothorax. So you see something like a white on the right and the left little bit blacker. So in MAS, like in RDS, I told it is profound pulmonary under aeration. The hallmark of MAS is usually it is an overinflated film. First point. Second point, in RDS, we usually say the findings are homogeneous. That is homogeneity of the findings. You usually don't see an asymmetry in RDS. The finding on the right will be more or less similar as the finding on the left. Whereas in MAS, the usual finding is heterogeneity. So on the right side, you can see some opacities. So they are called the typically described finding of our MAS is nodular or fluffy infiltrates that can be unilateral or it can be bilateral depending on the degree of collapse as well as the compensatory or the ball valve air trapping mechanisms. Okay, so you see bilateral, nodular or fluffy infiltrates, heterogeneity of the finding, and hyperinflation. That is, RDS is an underinflated, whereas your MAS is a overinflated film. You can count the number of spaces 1, 2, 3, 4, 5, 6, 7, 8, more or less like 9 spaces. Okay, so the heterogeneity of the findings is your hallmark of your MAS. And you see over aeration with focal areas of air trapping. And because of this overinflation, the diaphragm will sometimes be flat. You see streaky and patchy densities with large clear areas. Why this happen? Because of your collapsed alveoli as well as your distended alveoli. So we see a mixed pattern. And MAS babies is the one where on treatment, they are prone for air leak, particularly when you apply positive pressure. So in MAS babies, when you apply positive pressure, they are more prone for air leaks because one is they are already hyperinflated lung. And the second thing, complication of MAS will come. And sometimes you will see findings of like a superimposed pneumonia is there. Okay. So in MAS, the finding would be hyperinflated lung with patchy or fluffy infiltrates. Which can be unilateral or bilateral. Mostly the findings will be heterogeneous. Okay. Now, on this MAS baby, we started a CPAP. We started initially at 5, but you felt that, okay, we'll postpone the intubation, we'll like to increase the pressure a little more. We increased it to 6. The baby had a sudden deterioration at 12 hours of life. We called an X-ray. Now, what is it you are seeing? What is the finding which is seen on the X-ray? So we just now described what is the problem with an MAS length. Okay, so you have hyperinflation already, and on top of it, I have applied a CPAP of 5, and then I increased the CPAP from 5 to 6. So what is this? The finding which you are seeing? Okay, so I can see the chat. Yeah, pneumothorax right, pneumothorax right. So excellent. So this is actually a straightforward X-ray where you can see the collapsed lung margin on the right side. Now, with regard to pneumothorax, the immediate bedside test which I would advise the residents to do would be trans illumination. And in trans illumination, a halo of 1 centimeter is normal. Any halo of more than 1 centimeter around your trans illumination instrument is considered a positive sign. And make sure you dim the lights of the NICU. If you do the trans illumination with all of your lights on, you might sometimes miss it. Okay, so the role of X-ray comes particularly in case of smaller pneumothoraxes, because the bigger one usually it is picked up in your trans illumination, and also you can make use of POCUS also. POCUS where you can see the barcode sign and all. I think that's entirely different topic. So you can make use of trans illumination, POCUS. These are all methods. Not POCUS, lung ultrasound. So these are all methods to identify pneumothorax. But still, in majority of units, we use X-ray to confirm right pneumothorax. So here we have a right-sided pneumothorax, and we inserted. This is the same baby which was referred from the outside hospital. We inserted an ICD, and you can see the lung margin, collapsed lung margin. It has started showing signs of improvement. Okay, so this is trans illumination sign. This is what I was saying. A halo of 1 centimeter is normal. So here you can see the entire right hemithorax is trans illuminated. Okay. Now, these are particularly with regard to pneumothorax, the saying of you will not see what your mind does not know. This holds true because you should know what are the signs of potential air leak sites. So these are some of the potential air leak sites which you might miss. So air over the apex of the lung. Second, over the anterior surface of the right diaphragmatic leaflet. Third, between the lung and the heart. And fourth, uh, on the posterior surface of the both diaphragmatic leaflets. So these are some areas where you should have a focus when you are doing an X-ray for your pneumothorax. So these are small sites of air leaks. Okay. Now, this X-ray, can anyone say what it is? Chat box, what pneumothorax it is? The one on the right side. Pneumomediastinum. That's an excellent answer. Pneumopericardium. Okay. Pneumomediastinum, pneumopericardium, right side pneumothorax. Okay. So this is actually a medial pneumothorax. So by convention, we all know the previous X-ray. Now, two pneumothoraxes which you should remember is anterior pneumothorax and medial pneumothorax. Now, how do you differentiate between a pneumomediastinum and a medial pneumothorax? Now, I see if the pneumomediastinum, I think we have the X-rays. In medial pneumothorax, you see the air which is collected between the lung and the heart. So usually this is an advanced stage. Mostly you will see it in X-ray as the one on the left, like a thin rim of air between the left lung and the heart. Now, first thing to identify a pneumothorax is the sharpness of the ipsilateral cardiac border. So that is one finding which you get in anterior and medial pneumothorax. Because in place of the normal lung, it is the air which is abutting the heart. So you get sharpness of your ipsilateral cardiac border. And second thing which you differentiate from a pneumomediastinum or a pneumopericardium would be this pneumothoraces, medial as well as anterior, they'll not lift up the thymus. So in pneumomediastinum, you can see the thymus being lifted up. This pneumothorax usually causes compression of the thymus, wherein the thymus usually appears as sharp border. So here you can see this was anterior pneumothorax. Here again, compared to the left, you can see a hyperlucency. The right hemithorax is more dark. And second point is the sharpness of the right cardiac border. You can see the left side, it is the lung. So this is a little like a hazy margin. The margin of cardiac border with the thymus and left lung, it is not appreciable clearly. Whereas in anterior pneumothorax, you can see ipsilateral crisp, clear cardiac border. Okay. So sharpness of the ipsilateral cardiac border with a hyperlucency of right hemithorax, you should keep this also in mind. And anterior pneumothorax is one instance wherein you should, if the baby is not improving, you should you should do a lateral X-ray and see whether your ICD is in fact draining the anterior one or not. If you try to put the ICD more posteriorly, then you will be in trouble. It will not drain the anterior pneumothorax. Okay, so these are some potential air leak sites. Yeah, here here is the pneumomediastinum. Now in pneumomediastinum, the classical clinger in an X-ray for a pneumomediastinum is the thymus, which is lifted up bilaterally. You don't see this in your medial pneumothorax. So Ehrlich syndromes, we discussed pneumothorax, and in pneumothorax, two things I would like you people to take home. That is, one is the potential sites of Ehrlich, and also remember there are things called anterior pneumothorax and medial pneumothorax. Okay. Now, this is Ehrlich syndrome. That is your pneumomediastinum. Okay. There was one more Ehrlich syndrome. We'll see that. I think it will be coming in the subsequent slides. So we have a term baby born out of MSL with distress on head box, on oxygen. We are having a persistent desaturation. Okay, examination showed labile saturations with a pre-post dectal saturation difference of 10%. You did a chest X-ray. What is the finding? Can anyone put in the chat box? So what is the finding you are seeing? Pneumomediastinum. Okay. So you an X-ray with a setting. Just remember the clinical scenario. We had a baby with distress with some labile saturation and a pre-post-dectal saturation difference of 5 to 10%. 10%. Okay, so what are the answers? PPHN, excellent. Okay, so basically, the classical hallmark of a PPHN, if I don't have a scenario and if this X-ray is just shown to me, my first comment impression would be it's a normal X-ray. Okay, so PPHN, the radiological finding of a PPHN is pulmonary oligemia. Because of your oligemic lung fields, because of the increased vascular resistance, there will be less clear pulmonary vascular markings, first thing. And second thing, it more or less the X-ray findings are like a normal lung. And sometimes you may build, in case of severe PPHN, we are causing RA and RV enlargement, you might be able to appreciate an cardiomegaly and an RA-RV enlargement in case of a PPHN, but that again is you usually don't get in X-ray, because in PPHN, the classical diagnosis of a PPHN is with the help of your echocardiography, where you document the TR jet. Okay, so PPHN is persistent pulmonary hypertension of the newborn. Just remember, if someone asks you what are the findings, it is pulmonary oligemia with decreased vascular markings, and sometimes you may be able to appreciate your RA and RV enlargement. Okay. Now, we have a term baby, 37-weeker, born to infant of diabetic mother by LSCS. The baby developed respiratory distress soon after birth. We started on head box oxygen. The distress persisted even after 6 hours. We did a chest X-ray. So what is your finding? So I think, sorry, the answer has already come. I think the first X-ray, again, it is more like our previous X-ray with not much of a finding. So in TTN, this is one of the common scenarios you encounter for a term baby. So we'll go back to our earlier description of RDS and MAS. In RDS, I told the classical X-ray finding is an underinflated lung, whereas in an MAS, it is a overinflated lung. Now your TTN sits somewhere in between. It is never underinflated. It is moderate to severely inflated lung is your TTN. First finding. Second finding, you can see prominent fissures, your horizontal fissure. If you see a prominent fissure, it is most likely TTN unless proved otherwise. Because of the retained lung fluid, you can see this prominent fissures. So first finding, moderate to severely inflated lung with a prominent of fluid in the fissures. Third would be the one which is described in your Clohati, that is your radiating perihilar streakiness, giving an appearance of a sunburst. Okay, so you see radiating perihilar streakiness. So this radiating perihilar streakiness, it's a close. Sometimes your viral pneumonias can also present like radiating perihilar streakiness. So that again is a close TD when you have radiating perihilar streakiness. So fluid in the fissure, radiating perihilar streakiness with moderate to severely inflated lung. And the last finding, in some cases, you might also even get your pleural effusion. These are the findings of your transient tachypnea of newborn. That is overaeration of lung fields, fluid filled horizontal fissures, some pleural effusion you might get, and lungs with blood volume and some perihilar streaky opacities. Okay, so till now we have covered your RDS, MAS, TTN, your pneumothorax, your pulmonary hemorrhage, and your PPHN. Now we have a preterm here as a different scenario, 28-week and 940 gram baby on NIMV with settings of 20/6, 40 rates, 30% FiO2. Because of recurrent apnea, usually this baby was on a CPAP of 5. In view of recurrent apnea, we put it in an NIMV setting, and the settings is 20 of PIP, okay? 6 of PEEP. 40 rates, 30% effect, which is like a high setting on NIMB. On day 7, in view of this high FiO2 requirement, even on these settings, we put it on NIMB, but gradually you are seeing that the baby's FiO2 requirement is creeping up. You are finding it difficult to inflate the lungs. So we repeated an X-ray. So what is the finding? So I would request all of you to comment based on the clinical scenario. So we have a preterm who is on NIMB with little bit higher pressure. This is the X-ray you are getting. What is your finding? Answers in the chat. Okay, that's excellent, Prakriti. So this is so earlier someone told for that X-ray. The earlier these black opacity someone told PIE. Now what do you call this in PIE? Earlier we described the type 1 bubble. What is this one? Anyone? What do you call these bubbles? It was called type 1 bubble. The other one, this is called pulmonary hemorrhage. So in pulmonary hemorrhage, it will be told like it will be more opaque than this one. So in this one, the main finding is, so in PIE, I would the finding is pulmonary interstitial emphysema. Here, I would like request everyone to keep a magnifying glass in your unit whenever you read an X-ray of a PIE, because that is more appreciable when you use a magnifying glass. So what are these? What do you see? In fact, so you see tortuous radiation of these air streaks from the hilum. So from the hilum, you see tortuosities which are radiating to the peripheries, like serpiginous radiations of air. So this what usually happens is when you give increased pressures, once the air breaks, it can either break outside and cause a pneumothorax, or it can break into the mediastinum and cause a pneumomediastinum. Now, another option, what the air does is, this air along the bronchovascular sheath, it will from the alveolar space, it will rupture into the bronchovascular or the interstitial space, and the air gets trapped in those interstitial lymphatics. This is what is called your PIE, and it is also called your type 2 bubbles, compared to your type 1 bubbles, which we saw in your RDS. Okay, so in PIE, it is one of a condition with very stiffest of the lungs. We should be very wary, because once this such a PIE thing happens, be very careful with the amount of MAP or PI positive pressure which you are giving. Try to do a gentle ventilation. Otherwise, it's very difficult to ventilate or manage these babies. Okay. So that was pulmonary interstitial emphysema. Now we come across a 27-week, 870-gram baby on HFNC. Baby had recurrent apnea, increased FiO2 requirement and feed intolerance from day 21 because sudden worsening on day 21 requiring hiking of support, sepsis screen which was positive, and this was the X-ray. Okay, so what is the finding? Okay, so what is the finding you are seeing in this X-ray? So basically, this is like bilateral coarse infiltrates. Okay. So in RDS, we told finely granular reticularity. Here, what you see is coarse or patchy pulmonary infiltrates which are present bilaterally. So a bacterial pneumonia usually causes bilateral coarse, patchy, parenchymal infiltrates. Here it is not like patchy, it is like more or less diffuse coarse infiltrates, nodular infiltrates you are seeing bilaterally in a baby who has worsened with a positive sepsis screen. And this is your neonatal sepsis or a pneumonia. Sometimes it, as I earlier told also, it can, viral pneumonias can also present as fine reticulogranularity, perihilar streakiness and all. So this is neonatal sepsis or pneumonia. It can mimic other lung conditions like your TTN, your bronchopulmonary dysplasias, your MS and all. But again, your clinical scenario would be the clue. The main thing to remember with regard to neonatal X-ray is neonatal sepsis in X-ray is bacterial sepsis tend to be like more coarser picture with parenchymal infiltrates. You don't get your typical consolidation as you see in older children. And second thing is viral pneumonias, they less commonly forms this patchy or coarse infiltrates. They form perihilar radiating streakiness or infiltrates. Okay. Now, this X-rays, I am like, we have like something like 5 X-rays. Can anyone comment on what is this? I have not put any scenario. VAP, NEC dilated bowel. Okay. Okay. So any answers? What are those? So aspiration, collapse, consolidation. Okay. So at least I got a word of collapse. So good. So what you can see is you can see in all these X-rays, the one on the right side, you see it's more like an image A, where you see a sharp margin, sharp inferior margin. So in case of consolidation or pneumonia, you don't get this sharp margin or a collapsed lung, collapsed margin. So this is a right upper lobe collapse, okay, where you get the sharp margin. Very common if you put the endotracheal tube particularly to one side rather than in the center. And also sometimes in post extubation, again this apical lung collapse is the one which is commonly seen. Now these two are your middle and your lower lobe collapse, where you can see that the right diaphragm is superior diaphragmatic margin is lifted up by this middle and lower lobe collapse. And your image C is your collapse of your left lower lobe and the lingular margin. This image C. And again, image D is your left upper lobe collapse. Okay. So this again, images C and B, you less commonly you encounter in clinical practice. At least image A, you keep a photo of that in your mind. A lung collapse, usually characterized by the sharp or crisp inferior margin. Okay. And next is we have a 27-week 870 baby required prolonged. Okay. This I think is our second to last scenario. Okay. 27-week 870-gram baby requiring prolonged ventilation and prolonged oxygen supplementation till 36 weeks PMA. We are unable to wean off with recurrent episodes of desaturations. So this baby required oxygen supplementation till 36 weeks, okay? And we are unable to wean off this baby. So that is your clinical scenario preterm. You are being unable to wean off at 36 weeks. So what is your finding? Maybe I'll go give a clue. Sepsis screen is negative. What is your finding? What is your finding? Yeah, BPD. It's uniformly BPD. So this again, if it can mimic a finding of your bacterial sepsis also. So earlier BPD, this is the one which you classically see in your textbooks. Earlier, in the your non-invasive and the pre-surfactant era, where the bigger babies were ventilated for prolonged periods, there you usually got used to get this stages, distinct stages. And it is easily remembered as stage one is like an RDS with air bronchogram and reticulogranularity. Stage two is irregular densities and like patchy densities with interstitial edema. Stage 3 and 4 are where you get cystic changes start appearing. And in stage 3, there are cystic with hyperinflation and atelectasis. Stage 4, the cyst become more pronounced and you also get massive lung fibrosis. So old BPD, if someone asks you what are the stages, stage 1 like an RDS, stage 2 irregular densities and interstitial edema, stage 3 small cyst with no fibrosis, and stage 4 with generalized cystic areas with the areas of fibrosis. Now, with current neonatal practice where left, right, you see babies of 25, 26, 27 surviving with so many non-invasive options, CPAP, HFNC, NIMV, nasal HFO. So here, what you currently see is your, okay, these are the stages of old BPD. Stage 1, like your RDS. In stage 2, you can see interstitial irregular densities. Stage 3, you can see cysts which are appearing. Now, just compare, remember your PI X-ray in this. So in PI, it is very smaller, tortuous ones. Here you see big generalized cyst changes. And the fourth stage is the one X-ray which you people all answered correctly, the fibrotic one. But as I told, with the current neonatal practice, what we usually see currently is new BPD changes. And many a times it is haziness or diffuse granularity. And that is your type 1 BPD. And type 2 BPD is hyperinflation with coarse interstitial densities, more like your pneumonia-like type of picture, with hyperinflation with coarseness of interstitial densities. Okay. Now, this BPD change in any baby starting after 14 days of life, you should keep this differential in your mind when you are reading an X-ray and whenever you get features of irregular densities, interstitial densities, cystic changes, fibrotic changes and all. Because starting from 14 days, we give a diagnosis of evolving BPD after 2 weeks. And you give the diagnosis of established BPD only when the baby reaches 36 weeks. Okay. So this again is Potter. I'm not asking because I think everyone of you will answer. So this is congenital diaphragmatic hernia. So you see the left diaphragm is breached. The entire bowel is in the left side, causing the mediastinal shift of the heart to the right as well as your trachea. And this again, a left one with liver inside the abdomen because liver up is a bad prognostic sign. Okay. So this is like a milder variant, left side CDH. So this is a right side CDH. In right side CDH also, sometimes the liver chances of liver herniation is more with your right side CDH. Okay, and now anyone for these two X-rays, what is the finding? The one which is just showed, these two images. I think the lateral one is a clue. Anyone? Any answers? Morgagni, excellent, excellent. Okay, eventration. Okay, so here you can see a small bowel loop which is herniating on the lateral film. In anterior film, you see, if you see closely, you can see in the retrocardiac, you are in the cardiac area, you are seeing a little hyperlucency of that bowel. So Morgagni hernia very rare. Okay, 85 to 95% is your left side or your Bokdalak. Morgagnian is the anterior hernia. Now in eventration, you don't see the bowel in the thorax because what is eventration? Here, the right hemidiaphragm is pushed upwards. There is no breach of the diaphragmatic margin. Okay, so that is how you differentiate between your eventration and your CDH. Okay, so this again is a spotter. What is your diagnosis? I think the clinical image is the clue. What is it? The clinical image is the clue. Tough. I think it's too much easier. So, it is the one on the left is pure esophageal atresia. The one on the right is esophageal atresia with TEF. Okay. Now, all in TEF, the one thing you people all should remember is many surgeons insist that simple passage of your NG is not enough. Sometimes because recently also in our nearby hospital we had a case where the NG was going, but luckily they didn't start feed for that patient. So some people insist on a bigger size NG or a 10 French red rubber catheter to be passed so that your diagnosis is confirmed. Okay. Contrast studies had little risk, and also there is risk of aspiration. And always do X-ray of chest and abdomen, okay, when you are suspecting TEF, because 6% of TEF are associated with dual atrachia also. Always look for ARM associated. And if the other also, in 7% of neonates with ARM, they will have esophageal atresia. So, in case of TEF, always look at the anal opening. If the anal opening is option, also always ensure that you are not having an esophageal atresia. Okay. And in ARM plus esophageal atresia, never do invertogram. Anyway, that is also like less being done for ARMs nowadays. Okay. And so this is, I think, our last scenario. We have 31 weeker, 1.3 kg, CPAP till day 7. On day 14, the baby had worsening with reinitiation of support. Okay. So this baby, the baby from day 7 to day 14, baby was off support. Okay. Baby was on room air. On day 14, had worsening and requiring reinitiation. Subsequently, he's on CPAP. We are not able to wean him once he had the secondary worsening. We did a sepsis screen, negative. H1N1, negative. We did an X-ray. And this is what you are seeing. Okay. So suppose in the stem, if I would not have said from day 7 to day 14, he was off room air, what would be your answer? Clear-cut answer. It's a BPD. Okay. So this is BPD like X-ray change, but in between you are seeing what you see. From second week, the baby was absolutely free and room air, because in BPDs, classically, the baby will be on that support which he has been from the birth itself, whatever may be the support. So whenever you see such a scenario, this is where you suspect interstitial lung diseases. Here, X-ray alone won't suffice. You might even go for HRCT. So my take homes would be, first, you should know when to do and when not to do. The paraphernalias or the correct technique to do an X-ray, you should be very clear. Always read an X-ray systematically. Remember your ABCDF approach: airway, bones, cardiac, diaphragm, extras where you have the UAC, UVC, PICC line, and your ET tube and the fundic bubble. And the third point is the most important point, because this, I think, is like a theoretical scenario of the class, because you don't get it like this in your clinical practice, because clinical correlation is a must, because many of these findings are overlapping. Your TTN with pneumonia, your BPD with your ILDs, your mass with a pneumonia. So clinical correlation, whenever someone gives you an X-ray, okay, what is the condition of the baby? That should be your first question, because if it is an MSL baby, term baby distress, okay, you'll be looking out for a mass. A baby who is on high settings on NIMV, or a MS baby with high positive pressures, I'll be watching out for a pneumothorax. So clinical correlation is a must. And identify the patterns, that is RDS, underinflation. Mass, mostly it is an overinflation. TTN, moderate to well-inflated lung. Okay, so identify these patterns of typical diseases, and then understand the variations. Okay, so I think that's it. Thank you all.
Thank you, Shamnath, for that extensive coverage of almost all the important conditions of and neonatal X-rays. I'm sure the class would have been really helpful for all the those fellows, not only for the exam point of view, but also for their career onwards in neonatal practice. So it's already late, I guess. Girdhar sir, can we just wind off, and good night to all.
Yeah, thank you all. Thank you, Shamnath, for the excellent session. So please do join us for the next week's NOEL session. The topic will be intimated shortly. Thank you.
Thank you,
Thanks,
sir.
Vinay.
Thank you.
Yeah.
Thank
Good
you.
night.
Thank you.
Good night, dear.
Good night. Thank you.